Okay, so we're going to talk about chapter 20 today, the cardiovascular system, specifically the blood vessels and our blood pressure. So we're going to compare and contrast the anatomical structures. We're going to accurately describe the forces that account for capillary exchange. We're going to list the major factors that affect blood pressure, blood flow, and resistance. We're going to describe how blood flow, blood pressure, and resistance are going to correlate and interrelate with one another. We're going to discuss how the neural and endocrine mechanisms maintain homeostasis within the blood vessels, and we're going to describe the interaction of the cardiovascular system with those of the other systems. So let's just review really quickly our cardiovascular circuit. So the heart sort of in the center, right? And when we get that deoxygenated blood in from the vena cava, it has to go through the pulmonary artery to the lungs so that it can get oxygenated through a capillary bed within the lungs, and then down through the pulmonary vein to go back to the left side of the heart. And then we're going to take that oxygenated blood out through the aorta into all of the major vessels of the body. So we're going to send this oxygenated blood through the arteries to capillary beds, so we're going to have gas exchange, and then we're going to return through the veins back to the heart. So let's look at some blood vessels really quickly. So this is an artery and this is a vein, and you should be able to see that they all have that tunica externa, tunica media, and the tunica intima right there, okay? But there's a little bit of difference in them. So we have the tunica externa is a dense, irregular connective tissue. It has collagen, so that allows for tensile strength so that we can prevent any rupture from happening because there's a pretty strong flow of liquid or blood coming through them. The tunica media is circular smooth muscle. It's under our autonomic control of the nervous system. So we can vasoconstrict with our parasympathetic nervous system, or we can vasodilate with the sympathetic nervous system, and then we can redirect the flow as necessary. You'll see that in the veins, it is thinner. And then the tunica interna is made up of simple squamous epithelium. As we remember, simple squamous epithelium we most often find to reduce friction. Okay, and that's going to give us a friction-free surface for the blood to flow through. Another thing to note is that on the veins, that tunica externa is a little bit thicker, and that's because the veins tend to sit closer to the surface of the skin. There's different types of arteries. There's the elastic arteries. These are going to be the largest arteries that we have within our body. They're going to contain elastin for stretch and recoil. That helps to accommodate when we have this stroke volume as the blood is passing through, and that's going to do that without raising our blood pressure to extraordinary levels. We have our muscular arteries, and then we have the arterioles, which are going to be the smallest ones. We have some medium arteries. They're going to have an increased layer of smooth muscle. They help to redirect that blood flow as necessary. And then here's the arteriole. This is our small arteries that's going to take the blood directly to the capillary beds within the body organs. So atherosclerosis is where we get a buildup of plaque within the artery, and it actually will narrow that artery opening. The opening is called the lumen. And when that happens, it's going to increase the blood pressure because we have to push harder in order to get through the smaller opening. These are our capillaries. So capillaries are microscopic channels, and they supply blood to the tissues in a process called perfusion. Okay, we have an exchange of gases here, right? We have the oxygen and the carbon dioxide. We also have some exchange of other substances that occur in the capillaries between the blood and the surrounding tissues, and then their tissue fluid. The tissue fluid is called interstitial fluid. We have simple squamous epithelium here. So remember that squamous cells are those little pancake-like cells. They're really flat and small, and simple means that it's just a single layer. And that means that they can be either tightly packed together or loosely packed together. And that's going to allow certain substances to sort of leak into the tissues or into that interstitial fluid. So the blood flow is coming in here through the artery into the arterioles, and it's going to flow in this direction. Okay. And then we're going to get it back through the venules and then into the veins. So you can see that we're changing color as we're moving through, and that's to indicate the exchange of the oxygen and the carbon dioxide. There's different types of capillaries. We have continuous capillaries. That means that they have a continuous basement membrane, as well as this endothelial layer here is really tightly packed together, and very small minuscule holes between them. We have fenestrated capillaries, and fenestrated means pores. So there's little pores within the basement membrane here. Within the endothelial layer right here. And we have a complete basement membrane. And then we have sinusoidal. And so in the sinusoid or sinuses are larger holes. Okay, so we have lots of gaps between the cells as well as an incomplete basement membrane. So we're going to allow larger molecules to pass through. So this is that continuous membrane here. You can see that continuous basement membrane as well as the endothelial layer has those tight junctions. This is going to allow for the passage of water and ions. We're going to find this specifically at our skin, our brain, and our testes. These are the fenestrated, so you can see those fenestrations here, the pores. Okay, we also have tight junctions within that endothelial lining. We're going to allow larger molecules to pass through here, like in our small intestines and our kidneys. And then sinusoidal is where we're going to have any cells being able to migrate through, like within our spleen, our bone marrow, and our liver. So this is the capillary bed. So we have that arterial flow into the capillary bed, and it does that through what's called a meta-arteriole. The capillaries are then going to branch off of that meta-arteriole to create that capillary bed. We have pre-capillary sphincters right here. They surround the start of that capillary and they can regulate the blood flow, right? If we wanted to just have the blood flow through the meta-arteriole and skip the capillary bed, we could do that. Like when we're cold, for instance, we do this. The distal ends of the capillary are going to enter into the thoroughfare channel right here, and that delivers the deoxygenated blood into the venous system. So the capillary bed does not need to use those pre-capillary sphincters to close the blood. It can go directly here, directly from that meta-arteriole into the thoroughfare channel. So it doesn't, again, have to pass through the capillary bed. So what is capillary perfusion? Well, let's just talk about some different pressures first. So we have hydrostatic pressure. Hydrostatic pressure is the blood exerting the outward force on the capillary wall. Okay, so hydrostatic pressure that enters into that capillary bed is about 35 millimeters of mercury, while at the venous end, the capillary is about 18 millimeters of mercury. Okay, so here, 35 millimeters of mercury, and over here, 18 millimeters of mercury of hydrostatic pressure. This is, again, is that pressure pushing out. It would be like if you turned on a water hose and you turn it on full blast, that pressure of the water going through the hose pushing against the outer part of the hose. Okay. Osmotic pressure is a little bit different. This is a force generated by these large plasma proteins like albumin in the blood pulling the fluid into the capillary bed. Osmotic pressure is unchanged throughout the capillary and it's 25 millimeters of mercury. Oops, I'm going in the wrong direction. Apologize. 25 millimeters of mercury all the way through, right? So on this side, we have high hydrostatic pressure, low hydrostatic pressure, but the osmotic pressure is consistent all the way across, okay? And so what we have is that there's different pressures along it, right? So the hydrostatic pressure over here, 35 millimeters of mercury, it's higher than the osmotic pressure of 25 millimeters of mercury, okay? 35 minus 10 is, 35 minus 25 is 10 millimeters of mercury, right? And so that's our filtrative force. It's pushing through. And then on the other end, we have a reabsorption factor happening, okay? And that's because the hydrostatic pressure goes down to 18 millimeters of mercury. The osmotic pressure remains 25 millimeters of mercury, right? 18 minus 25 is negative 7 millimeters of mercury, okay? And so we're going to get a reabsorption occurring. So at the arterial end, we have the hydrostatic pressure. The hydrostatic pressure pushes out minus the osmotic pressure of that pull in. 35 minus 25 is 10 millimeters of mercury net filtration. This is pushing out the fluids and the nutrients into the tissues, into that interstitial fluid. At the venous end, hydrostatic pressure pull out minus the osmotic pressure pull in. 18 minus 25 is negative 7 millimeters of mercury. Net filtration pressure. So we have that net pull in of those fluids and waste. The overall hydrostatic pressure is greater than the osmotic pressure of about 3 millimeters of mercury. That means that some fluid is going to be left within those tissues, and that's going to be removed by our lymphatic capillaries, and then it's going to be placed back in the bloodstream via the subclavian veins. Okay, so we have those lymph. That's where lymph comes in. This is just a little diagram to help show you. So here's filtration happening right here. Okay, the fluid exits that capillary since capillary hydrostatic pressure of 35 millimeters is greater than our blood colloid osmotic pressure of 25. We're going to push out of our vessels. The center, not really a whole lot of movement happening because they even out at 25 and 25. And then on the venous end, we get a reabsorption happening because here our osmotic pressure is higher than the hydrostatic pressure. This is actually how we get lymph, right? Because we get that 3 millimeters of mercury sort of leftover pressure and therefore leftover fluid within the interstitial fluid. That interstitial fluid or lymph is going to go into our lymphatic vessels that are kind of intertwined within our capillary bed. So let's talk about veins. So veins hold 64% of the systemic blood flow as capacitance vessels. So that means that you would sort of expect like 50-50, right? 50 for arteries, 50 for veins. No, more is being held within our veins. These are called thoroughfare channels, and they flow into the venules. Remember, we talked about those thoroughfare channels here. They're going to flow into the venules and then flow into our larger veins. Oops. So the large and our medium-sized veins actually contain valves. They're very similar to the semilunar valves, and they prevent any backflow within the venous system because it does not have a true pump. The skeletal muscle massage. Remember, every time we move our muscles, our skeletal muscles, we're actually constricting on to our veins, and that helps to push the blood up through the valves. Okay. Then when we're not pushing, then those valves can close back down and the blood cannot flow in a backwards direction. Sorry. This also happens with respiratory forces to help move the venous blood from the body back into the heart. Okay. So here's that skeletal muscle massage and those valves functioning, right? We're going to constrict these muscles right here. They're going to push on to the blood vessel, okay? And that's going to force the blood up through the valve. So respiratory forces. So when we inspire or we take a deep breath in, our diaphragm actually flattens and pushes down onto our abdomen, okay? And that's going to increase our abdominal pressure. At the same time, we have a negative pressure created within our thoracic cavity where our lungs sit. So the venous blood is actually going to move in the direction from the higher to the lower pressure. So it's going to move from the lower extremities in the abdomen up into the right atrium via that inferior vena cava. So blood pressure is determined by cardiac output times systemic resistance. Okay, so BP equals CO times R. So cardiac output has to do with our heart. Resistance really has to do with the blood vessels themselves. So what kind of resistance are we receiving within the blood vessels? Okay. Blood pressure is measured in millimeters of mercury of systolic over diastolic blood pressure. We talked about systole and diastole when we talked about the heart. So go back and review that if you need to. So that systolic blood pressure represents the force of flow generated when the left ventricle during systole. Usually a normal blood pressure is considered about 20 millimeters of mercury over 80 millimeters of mercury. So that 120 is the systolic. The 80 is the diastolic. Diastolic represents that back pressure of the vascular system during the diastole, and the blood pressure dissipates as the arteries branch and get smaller and smaller. But we can see that it actually stays about the same all the way through our muscular arteries, okay? And muscular arteries would be like those arteries within the arm as we take blood pressure in the arm for that particular reason, because the pressure is about the same as it is at the aorta, as it is within the muscular arteries. It's not until we hit those arterioles and then our capillaries, and then you can see as we go down, look at that pressure at the vena cava, very low. So resistance is often called afterload. We talked about that when we talked about stroke volume. The tension that the ventricles must develop to pump the blood effectively against the long and ever narrowing vascular system. So factors that increase resistance will also increase blood pressure. So decreased blood vessel diameter. Now our body does this naturally. We can decrease that blood vessel diameter. However, we also do this when we have atherosclerosis. We get that plaque buildup, okay? We increase blood vessel length. This happens as we gain weight. As we gain weight, we have to be able to vascularize all of the extra fatty tissue. And so that increases our blood vessel length. This also happens during pregnancy, hence the reason that people who are pregnant are monitored blood pressure very closely. And increased blood viscosity. So during dehydration, for instance, our blood becomes a little bit more viscous. And that can cause us to have an increase of blood resistance and therefore an increase of blood pressure temporarily. But also there are some different diseases that increase blood viscosity, and therefore we're going to have an increase in resistance and therefore an increase in blood pressure. Diets high in fatty foods can also do this. So blood vessel diameter is under control of the vasomotor center, which is found in the medulla oblongata. So we have that parasympathetic stimulation via our vagus nerve of the smooth muscle in the walls of the blood vessels. It constricts the blood vessels somewhat kind of all times, right? So this gives us a 24/7 regulation of blood flow. So the parasympathetic nervous system can actually decrease the action when we need more flow. Okay? The parasympathetic nervous system vasomotor center is going to send signals via the vagus nerve to the smooth muscles in the tunica media. Remember, that's that coating on the outside of the blood vessels to contract. When we vasoconstrict, it increases resistance. Okay, so this is vasoconstriction, right? So when we constrict, we're going to have more pressure because of more resistance. Think about those really thick milkshakes, maybe. Anybody ever had a really thick milkshake and you get that really skinny straw and you like suck as hard as you can, but you cannot get the milkshake up your straw, right? So same idea here. It takes so much more pressure to get it through that narrow straw than it would if you had a really big fat straw. Okay, so this is kind of that idea. We have alpha 1 stimulation and beta 1 stimulation depending on what we're going to do. Okay, so sympathetic stimulation relaxes those smooth muscle in the blood vessels, so we get a vasodilation when more blood flow is needed. The sympathetic nervous system vasomotor center operates via the lateral horn of the spinal cord to the sympathetic nervous system ganglia via norepinephrine to trigger the beta receptors of the smooth muscles to relax. So we get a dilation. The vasodilation decreases resistance. During exercise, epinephrine from the adrenal medulla triggers the beta receptors within the blood vessels of the heart, the lungs, and the skeletal muscles to vasodilate. Okay. And while the norepinephrine from the adrenal medulla triggers the alpha 1 receptors in the blood vessels of the skin and the GI tract to constrict and divert blood flow. So that explains sort of during our sympathetic nervous system response of fight or flight, which we also get during exercise, that we're not going to go through those digestive organs. We're going to put the blood flow into our skeletal muscles so that we can exercise more and into our heart and our lungs for the breathing and the heart rate. Okay, so we also have baroreceptors and chemoreceptors. These are specialized receptors within the carotid sinus and the aortic arch, and they interact with that vasomotor center to help regulate our blood vessel diameter. The baroreceptors, they sense pressure changes, right? So if the blood pressure is too high, then the sympathetic nervous system vasomotor center is going to vasodilate those blood vessels, and that's going to, because it's decreased resistance, it will then decrease blood pressure, right? Because blood pressure equals cardiac output times resistance, okay? The opposite will hold true if our blood pressure is too low. We will vasodilate so that we can increase resistance and therefore increase our blood pressure. Chemoreceptors are going to sense changes in oxygen, carbon dioxide, and pH. If our oxygen is too low, carbon dioxide is too high, or our pH is too low, then we'll vasodilate the blood vessels to get more oxygen to the tissues and more carbon dioxide to the lungs so that we can excrete or exhale it out, which will hopefully improve the pH. The cardioacceleratory center will also increase the heart rate. So once we hit adult size, blood vessel length is usually pretty stable, but during increasing obesity, we can get a higher blood vessel length, right? And that's because adipose tissue or fatty tissue is very vascular. Increasing blood vessel length is going to increase our resistance as the heart has to pump harder to reach that further distance. This is why obesity can cause hypertension. The blood pressure is going to rise to a level of over 130 over 90 or higher. That's considered hypertension. Blood viscosity has to do with the number of blood vessels or red blood cells, present in the blood. It's usually stable over time, again, once adult size is reached. However, anemia can occur. The blood will become thinner, causing less resistance to blood flow. And we also have polycythemia vera, which is a disease where the bone marrow overproduces red blood cells. The blood can become very thick. Thicker blood creates more resistance to flow. Let's talk about some hormones that can affect blood pressure. Okay? So when we have a decrease of blood pressure or blood volume, on the short term, we're going to get sympathetic activation. So our adrenal glands are going to release epinephrine and norepinephrine. They're going to increase our cardiac output and also increase our peripheral vasoconstriction. So if we increase cardiac output and we increase vasoconstriction, which therefore increases resistance, okay, because we're making the vessels smaller, that's going to increase our blood pressure. Okay? We're also in the long term, our kidneys are going to release renin, which is going to start our RAA pathway that we've talked about. So we get renin, we activate AIM2, that are then going to stimulate aldosterone and ADH to be released, which can increase our cardiac output and our peripheral vasoconstriction. We're going to stimulate thirst, which is going to increase our blood volume. Okay? These are going to act at the kidneys. And we're going to release EPO, erythropoietin, which is going to increase our red blood cells. They're going to increase blood volume. When we increase both blood pressure and blood volume, we hopefully will bring our blood pressure and our blood volume back to normal. So this is showing you sort of our differences between our nervous system response and our endocrine system response, okay? So same information, just broken down a little bit differently, okay? So in the endocrine, we're going to release hormones, right? So ADH, ANG2, aldosterone, EPO, they're going to increase blood volume, okay? And when we increase blood volume, we increase blood pressure. They are directly related. And then in the neural mechanisms, right, so we have our baroreceptors and our chemoreceptors. We have the cardiovascular centers are going to be stimulated. So typically, we're going to stimulate that cardioacceleratory center. And we're going to have the release of norepinephrine and epinephrine. So we're going to increase cardiac output. We're going to increase blood pressure, decrease that venous reserve, and hopefully that's going to put our blood pressure back to normal. We also have some autoregulation of local blood pressure within our tissues. Okay? Endothelin is released when we have any damaged endothelial cells. That triggers local vasoconstriction to help stop bleeding. Nitric oxide can be released by those same endothelial cells when we have low local oxygen levels. We can trigger vasodilation. And we have what's called the myogenic response, our smooth muscle stretch response in our blood vessels. When we get too much blood flow, we can vasoconstrict. Too low blood flow is going to vasodilate. You know where to find me. If you have any questions, please review the objectives and make sure that you're good with those. If you have any questions, please reach out.